Is there a clicker? No worries, I can try to stay here. Cool. And I just hit this one? This one.
Sorry. Yeah.
Okay. Okay. Good morning. Can everyone hear me? Wonderful. Sorry for the delay. There were some technical difficulties. My name is Dr. Casey Kidd. I use she, her pronouns. And this morning, you're getting a lecture on LGBTQ plus health. And I do know that this is round 2. I know that you had a lecture on this topic a week ago-ish. And I got to watch that lecture, so I promise I'm not going to rehash last week's lecture. So hopefully this will be an expanded version, a 102. So disclosures for today, I will talk about a couple instances of both generic and brand name medications. I am a pediatric gender affirming care physician and a researcher. My research focus is improving health outcomes for gender diverse youth and their families. And so certainly there are some biases associated with that. I'm very passionate about the work that I do. Additionally, my own identities are complicated, but I live a very cis-het privileged life, and that's important to understand kind of my positionality in all of this as well. We've got 3 learning objectives for today. The first is to demonstrate competency in using language relevant to LGBTQ plus community, examine historical and modern sources of health inequities for this community, and appraise opportunities for reducing those health inequities for patients, colleagues through case-based learning. And feel free at any point to interrupt me. That goes for the folks on Zoom as well. I'm not great at paying attention to, I don't even know if there is a chat, but if there are any questions from the Zoom folks, please interrupt.
Excuse me, would you be able to share your screen?
Sorry, more tech complications. You've missed out on some very exciting rainbow slides so far. Can we confirm that we're good?
Yes, thank you.
Excellent. Okay, and we're back. So what you missed so far, Zoom folks, is pretty slides, disclosures, learning objectives, and here we are. So I know that you had a 101 course on language a week ago. I'm hopeful that unlike when I was a medical student and a college student, I'm hopeful that you have actually had training on this topic prior to being here, because times they are a-changin'. But it is important to recognize that language is always evolving, right? You need to embrace being a lifelong learner in all aspects of the work that you do and will do, but particularly when it comes to language, and especially language relevant to this population. So I'm going to go ahead and jump ahead and expand us from LGBTQ plus to LGBTQIA2S plus. All right, so let's go over what those other letters are and number. So you already know the lesbian, gay, bisexual, transgender, queer, sometimes questioning, intersex, and asexual. That stops us at the A. 2S is for two-spirit. And so two-spirit people it's kind of an umbrella term for people who are of Native or Indigenous ancestry who embrace both the feminine and the masculine aspects of who they are. And so these folks traditionally were seen as spiritual leaders, as healers, as people of high regard in tribal communities, and continue to this day. But this is something that is increasingly present in the acronym to give kind of special space for this group of folks. Okay? And then some other words that I wanted to make reference to. So pansexual is a word that I increasingly hear from young people. I've actually had older community members say, that's not a real thing. In fact, it is, and young people invent language and are the drivers of language evolution. And so it's important for us to recognize that when young people create terms, we need to elevate those as well. And so pansexual refers to someone who's attracted to people for who they are and not necessarily what body parts they have or how they identify. It's kind of an expansion on bisexual, although many people who are attracted to people in the way I just described would also consider themselves bisexual or would consider themselves bisexual and not pansexual. And all of this essentially boils down to you will be tested on things like this, and so I want you to have a conceptual understanding of the differences. But really what matters is what matters to your patient and whether or not language and labels matter to them. Okay, so that's kind of the practical aspect. But that's pan. And then there's ace-aro. You already know these. This is asexual and aromantic, but you may not recognize it if a young person comes in and says, well, I'm ace-aro, right? Or aro-ace. And then envy. And so NB is the way that you write out, one of the ways that you write out non-binary. You don't really say NB because NB traditionally means non-black, okay? But NB written this way refers to non-binary folks. And so I just wanted you to see that, so in case that comes up, you recognize what people are talking about. And if this is something that you want to know more about, I recommend these 3 sources. So I tried to QR code things because I'm super hip like that. I recognize that that's not actually the case. But you can scan these and get links to all of these things. So this is actually the GLAD Terminology Guide. This is an article by a colleague and friend of mine, Florence Ashley, that is very thorough. And then this is a book that I have that I love. And so if you really want to dive in, that's a good opportunity. I know you have plenty of spare time. So this is a list of things to say and not say about gender diverse people. And so when we say someone is transgender, we say they are transgender, not that they are transgendered. We don't say that. We don't say that someone is a transgender, right? We say that they are a transgender person. And we don't make excuses to justify our own failings in using someone's proper pronouns, okay? And so you're not going to say, oh, your pronouns are hard. If I mess them up, just like, you're going to have to let that go. That's not great, right? Instead, you do your best, right? You're going to, did I mess something up again? Thanks. We're going to set the mood. So if you make a mistake, correct yourself, apologize, move on, and vow to do better next time. Because if you do something different, for example, if you say, oh my gosh, I'm so sorry, I didn't mean to mess that up, that was really hard, I don't even know what I did, I feel bad, you're probably embarrassed, I'm embarrassed. You make that person feel like they need to say, it's okay. And they shouldn't be making you feel better about your mistake, right? And so you do your best when you make a mistake, because you will. Correct yourself, apologize, move on, do better. These words are offensive and outdated. The one exception, sort of, is this one. So transsexual is a word that some community members, especially older community members of gender diverse experience, use for themselves, okay? So this is not a term you're going to apply to someone else, but one that they could use for themselves. Other terms I do not recommend you use really in any context. Often in medical literature, you will see FTM and MTF, and that's female to male and male to female. You can understand that that's a pretty unidirectional binary model of gender that is not really reflective of a lot of people's lived experience, okay? It's medical short script for us to say, okay, does this person have a penis or not? Maybe, right? But people aren't that simple, and we shouldn't oversimplify our language when it doesn't really reflect who people are, okay? And then anytime you have to put the word real in front of something, you're probably doing it wrong, okay? So someone is not a real boy like Pinocchio, and so you don't want to have that in your documentation. And in the era of open notes, your patients are going to see what you write about them, right? And so it's not just like an exercise in I'm being affirming in the record, which you should do. You're also being affirming to support your patient and recognize that they are being seen and translate that to them, okay? So this stuff matters. I know you had the 101. Big question, is all of this stuff I'm saying going to be tested? 100% it is. It's going to be tested by me, but more importantly, this, if you scan it, is the content specification for the USMLE. And I have had questions like what I'm about to go over with you on almost every board exam I've ever had. It started during my in-trainings and residency, and I graduated from this School of Medicine in 2014. And so they've been present for a while, and I'm very confident, especially given the specs, they have trickled down into your exams. These are easy questions. You want these points. Okay, so let's not miss them. If a patient was designated male at birth, and that's the language, we don't usually say assigned as much anymore, we're moving towards designated, language changes. A patient was designated male at birth and identifies as female, this patient's gender identity is most likely which of the following. I have had a question, this exact question, on a big exam in the past. Okay, easy, easy question. So how do we do this? Volunteers? Okay, let's go through it. So we were assigned male, but we identify as female. So what takes precedence here is how we identify. So because we identify as female, but that is discordant with what we were designated, that makes us a transgender female. Now, that does not mean that this theoretical patient says, my identity is transgender female, right? This person might just identify as a woman. Right? This person might not have language for their identity. They might just want you to provide outstanding care to them. In fact, I guarantee they want you to provide outstanding care to them. But for the purposes of exams, this is a really important thing to know. Okay? Any questions about that? Okay, let's take it up a notch. So, patient was designated female at birth, identifies as non-binary and bisexual, and reports emotional attraction to males, emotional and physical attraction to females. That second part is just fluff that you don't actually need, like all questions. Okay? What is this patient's sexual orientation? And what is this patient's gender identity? Anybody? So we got to know the difference between sexual orientation and gender identity. Okay, I know it's early. So, sexual orientation has the word sex in it, so that's helpful, right? Gender identity, where you talk about non-binary, NB. Okay? So these are questions you must be able to get right. These are easy. Any questions about this? Okay. A patient explains that they are attracted to individuals of all gender identities. Which of the following is most likely to be this patient's sexual orientation? Correct. Okay. So why pan and not poly? Number one, I didn't talk about polyamory or polyamorous identities yet, so that's probably a good answer. But polyamorous is multiple people, usually simultaneously, not necessarily in the room or in the bed simultaneously, right? But simultaneously. Whereas pansexual is just exactly this, attracted to individuals of all gender identities. They might be pan and poly, in fact, a lot of my young people are, but that is not necessarily the case. And again, someone who says exactly this may not identify with this word, but notice that non-binary is not an answer on this list, and that's why this is the best answer. So, Test Strategies 101, this is the only answer like this. Yeah? Yep, and so non-binary is in Dr. Gannon's lecture, but, so non-binary is someone who really kind of rejects the idea of they must be masculine or feminine, or feels that they themselves are somewhere in the middle, or feels that they're kind of off of the spectrum of masculine, feminine altogether. And so it's really an umbrella term for those who do not fully align with the masculine or the feminine. And you can have aspects to your identity that are more non-binary, and aspects that are more binary. And in fact, limited evidence that I collected myself suggests that those folks who have both non-binary and binary identities may be at higher risk of some of these health inequities we're talking about. So important considerations when we're kind of going through big picture stuff. But really great question. Yeah. Any other questions? Yeah. Great question. Yes, to the second part. So you could be straight and be polyamorous, right? So heterosexual, someone who is attracted to someone of the opposite sex. And really we're kind of deconstructing the idea that there are only two options, right, masculine and feminine. And we're kind of moving into this gender idea where gender is a spectrum, but you can also be off of the spectrum, so it's kind of a three-dimensional spectrum. I know it's a little bit of a mind thing, okay? I've got great diagrams. Let me know. Email me. I'll send them to you. Okay. So that was demonstrate competency in using language relevant to the LGBTQ plus community. All right? And so I didn't delve in tons. Dr. Gannon's lecture does a little bit more. I'm happy to kind of go back and do the whole version of this, but my hope was that you've had this enough times that you didn't need the whole version. Okay? But if that is not the case, please let me know. I'm happy to talk about this forever. But next I want to look at the historical and modern sources of health inequities for this community. So you know from Dr. Gannon's lecture, and hopefully other experiences you have had in your life, that this population, again, here abbreviated the longer version, LGBTQIA2S+, people face significant health disparities. Okay, I could give you an entire lecture on these, but I really don't like doing that. Number one, because you've had it before. Number two, because individual numbers are not reflective of the incredible people I get the privilege of caring for. Okay? And really, number three, it doesn't do anything for you other than to teach you facts and statistics. I often have people come to me and say, okay, but how do I fix this? And so the rest of this lecture is going to be dedicated to helping you understand how you can fix this. Okay, so why do these disparities exist? They exist because of systemic inequity, stigma, discrimination, homophobia, transphobia, and racism. Okay? That one's a big one, and not one we talk about enough, because if you have intersecting minority identities, you're going to have a higher rate of all of these inequities, right? And so our trans folks of color especially are the most likely people to be murdered in our country and around the world. Okay? And so something important to pay attention to there. An additional example of this, so gender diverse young people have 2 to 4 times higher rates of depression and suicidality. That's the scare number that people talk about all the time, like the trans kids are killing themselves, and it is true. But if gender diverse young people feel supported at home, at school, and in their communities, they have the same mental health outcomes as their cisgender peers. And that's a big deal, okay? So we just got rid of 2 to 4 times higher rates of depression and suicidality by supporting and affirming the kids. And so that's what I've dedicated my career to, because this is a big number to me. And here are 3 studies that demonstrate what I just said, okay? Additionally, I think it's important to pause and say, being gender diverse and being LGBTQIA2S+ is not new. I already shared that Two-Spirit people are from indigenous cultures, right? This is not like TikTok. TikTok did not make Two-Spirit kids, okay? And here's a nice view. I completely kidnapped this slide from Dr. Stephen Deasy from psychiatry, so thank him when you see him. But these are ancient Mesopotamian sculptures that are non-binary by our current language. Obviously, the ancient Mesopotamians didn't have the word non-binary, okay? And so a lot of our reflection on history is through our own lens, and we have to recognize that. But being gender diverse is not new, okay? TikTok didn't make the kids trans either. If you, like me, get really nerdy about this kind of stuff, and you also have tons of free time, I know that you don't. But just in case you want a book to read after step 1, this is a tome. It's written by my dear friend, Jules Gill Peterson, and it starts at 1900. And it explores the intersections between intersex children, which we have not talked a lot about yet, but we will, and gender diverse people, so specifically trans and non-binary people, okay? Because when trans and non-binary people show up in our written history, it's often intersecting with medicalization. And that medicalization really centered around intersex kids in the early part of the 1900s. Okay, so fascinating book. This one just came out in November. Really into this. This is literally sitting on my nightstand right now. So this is a guy named Ewan Forbes. Ewan Forbes was born to privilege, was like a cousin to Queen Victoria or something fancy, was like the child of an earl or a duke or something in Scotland. Okay, and so Ewan was assigned female, was designated female at birth, and was a child of privilege, and so mom took Ewan on a tour of Europe around the time that puberty was happening in order to get access to synthetic testosterone, which was just being developed in the early 1900s. Okay, so Ewan transitioned, lived as male, was a family physician in rural Scotland, married a woman, had a lovely life. Until his father and his brother died unexpectedly. And in the UK, you can only inherit through the male line. And so out of the woodworks comes a cousin that says, no, I remember you were assigned female, and sues for the rights to this earldom, dukedom, whatever situation, okay? And so they tell you this right up front, so I'm not spoiling anything, but Ewan wins, okay? He wins that he is male, he has lived his life as male, he gets to inherit. But they were so scared of this case in the United Kingdom that they shut it down. They hid the case file, no one was allowed to talk about this until really the last couple decades, because this challenged this word I can't pronounce that essentially means things inherit through the male line, something, patrogenous, something. But anywho, so,
Patrilineal?
Say it again?
Patrilineal?
It might be patrilineal. There's a G in
Male
there.
primogenitor?
Yes, thank you. That one. Okay, thanks folks, this is amazing. Like, people from the sky answer my questions. But, so anyway, yeah, that. So it challenged that very kind of cornerstone of this society in a way that has negatively impacted the lives of gender diverse people ever since. Because now it is on their law books to be discriminatory as a result of the hiding of this case. So, fascinating, highly recommend. This is a much lighter read than this one, but both are fabulous. So I want to do a little bit of a timeline, okay? So forgive me as I literally march you through this timeline. Okay, so we're going to start at 1915, because again, I want to hammer home that this is not a new thing. TikTok didn't make the gay people or the trans people, okay? So we're going to start at 1915, and I'm going to highlight what I think are important intersections of this community and medicine, okay? This is not an all-encompassing history. Stonewall, for example, is not on here. If you don't know what Stonewall is, you really need to read about it, okay? But this is every time that medicine gets in the way of LGBTQ people's lives. Okay? So, 1915, the word intersex was first used in medicine. Prior to that, people were just different, and we didn't really do anything about it, and it was just a thing. Okay? We kind of recognized that there was a lot of inherent differences in what our genitals look like, especially. In 1935, this guy you may have heard of, named Sigmund Freud, wrote a letter to a mother who wrote to him in distress that her son was gay. And Sigmund Freud said, homosexuality is nothing to be ashamed of, no vice, no degradation, it cannot be classified as an illness. In fact, in kind of Freudian theory, he thought it was an underdevelopment of sexuality that was totally normal on the spectrum of human experience. Okay, Freud. That was 35. Freud died a few years later, and almost immediately upon his death, his contemporaries rebelled against this idea. They did not agree with Freud. Jumping back to the intersex, folks. So the first intersex surgery on a child, surgical reduction of the clitoris, was done in 1944. This was purely cosmetic. There is no reason to have cut into this child's clitoris. No reason. Other than, maybe this child's husband someday might not find it aesthetically appeasing. Okay? So that happened in 1944. In 1952, the American Psychiatric Association, again, really rejecting their dude Freud, classified homosexuality as a pathologic mental disorder. That was 1952. In 1965, Hopkins began offering gender-affirming surgery. So this was actually, because they had done so much work on intersex children, they were actually pretty good at doing what were then called, and it's now pejorative, sex change operations. Okay, so now we call these gender-affirming surgeries. This program was actually shut down a couple decades later and only recently restarted. But it did exist back in 1965. In 1966, there was a failed circumcision. And this patient's name, affirmed name, was David Reimer. And David Reimer had an identical twin brother, and the two babies had phimosis within the first year of life, and so it was recommended that they undergo circumcision. So David was up first, and there was some electrocautery technique that was not the standard Gomco-Mogan kind of things that we do now, and this led to a partial amputation of the penis. Okay? And so there was this psychologist, whose name is John Money, who worked at Hopkins, okay? And he had this theory that he really wanted to test. The theory was this learned gender identity. His theory was, if I change the physical appearance of a child and raise them as a different sex, then they will never have any issue with that our idea of gender is entirely learned. Okay? So he saw identical twins and an opportunity. And so this child underwent feminization surgery at like 22 months or something, had bilateral orchiectomy, had the creation of a vagina. Again, a lot of this is like, so future partners would enjoy it, that kind of ideology about what we do to children, okay? Their future sexual partner's interest. And so this child knew nothing about this happening. But John Money saw these kids constantly because now he had the perfect setup. This was the same home environment, the same parents, the same uterine environment. Everything was identical for these twins, except that one of them was being raised as female. So this didn't go well, okay? John Money wrote about this constantly. He wrote about it every time he saw these patients. He talked about how his theory of learned gender identity was the best. It was definitely accurate. Until David hit puberty. He had been raised as Brenda, I think, during that time. And at puberty, he began recognizing that he did not identify as female. Okay? And so really it kind of squashed this theory, but not for generations later, because it took a while for David to tell his story publicly. And thank goodness that he did, because his story was, please stop doing this to children. Mind you, unfortunately, he had a whole lot of things that did not go well in his life, and this was definitely one of them. He ultimately died by suicide at age 35. Okay? 1968, the American Psychiatric Association, remember these folks, reclassified homosexuality as a sexual deviation, which, I guess a win, it's a problem, right? So now instead of a pathology, you have a deviation. In 1970, activists disrupted the American Psychiatric Association's convention, okay? And these are activists who are saying, we are not sexual deviants, right? And then, in 1973, the American Psychiatric Association removed homosexuality as a mental health disorder, which, win, right? So what happened between these 2 years is really interesting. Every year, at the APA convention, activists got increasingly vocal about this and what garbage it was, okay? to the point where they had these panels and they had gay people and they had psychiatrists and they're all like, this is stupid, we shouldn't classify. And they really wanted a gay psychiatrist, okay? But that person would have been committing career suicide to go forward and say, I am a gay psychiatrist, I am your colleague. And so instead they found somebody who was willing to wear, literally, I kid you not, a hat and a wig to go and sit on this panel because they didn't want to be outed, because it was that dangerous for them. But ultimately that led to this, which is great. Except, in 1974, the APA was like, oh man, was that the right choice? I don't know. Let's take a vote. And so only 58% of them said, yeah, that's not a mental health disorder. 58% of people. Psychiatrists. Okay. In 1974, which is not that long ago. In 1980, so we kind of moved past the homosexuality thing, but now we're paying attention to these gender diverse people all of a sudden. Okay, so in 1980, the DSM-3 came out and talked about transsexualism for the first time. Okay. Then in 1981, we had the first cases of HIV identified. In 1987, the first HIV drug was approved, that's AZT. Unfortunately, this is $1987. It cost $8,000 a year. And so if you didn't have insurance, you were going to die. And you'd watched your friends die for the years leading up to this. So this is a problem. All right. Then in 1994, the DSM-4 had this diagnosis of gender identity disorder. So we kind of moved away a little bit from what was very parallel to a pathologic mental disorder, okay, that is transsexualism in the DSM-3, to gender identity disorder, which is kind of more in line to this sexual deviation sort of thing. Your gender diversity is still the problem. And then, jumping back to our intersex community, in 1996, we had the first demonstration by intersex people at the American Academy of Pediatrics conference, 1996. In 2000, the American Psychiatric Association recommended for the very first time that it was a bad idea to try to forcibly convince people that they weren't gay. And this is extended now to that they're not trans, but this is a recommendation, it's not like a ban. So Morgantown actually passed a ban last year. Okay, and as far as I'm aware, this is still happening in Morgantown. So it was helpful, I guess, to say it was bad. Then this is the American College of Pediatricians. Not to be confused with the American College of Physicians, which is a legitimate major medical organization. Instead, the American College of Pediatricians is a group of a couple of hundred of pediatricians. Back then it was like 50 pediatricians, not very many. But now it's like a couple hundred people who specifically formed in 2002 in order to oppose gay people adopting children. In their minds, gay people are the equivalent of pedophiles and they should not be allowed to adopt children. That is profoundly messed up, okay? And not at all based in any fact or science. But that's why this organization was formed. And so they equate those two things. They also oppose transition care for gender diverse people, especially gender diverse children. But this is classified as a hate group by the Southern Poverty Law Center, and that's why. It's because they actively discriminate against gay people, okay? And they promote legislation that does that. So that's why they're a hate group. That was 2002. They still exist. They still cause problems. In 2013, a couple interesting things happened. So the DSM-5 came out. I was in medical school, okay? And it replaced gender identity disorder with gender dysphoria. And so gender dysphoria is the distress associated with the incongruence between the sex you were designated and your gender identity. And you can see an interesting parallel there, because gender dysphoria kind of lines up with this journey about homosexuality, okay? So the DSM first said this is a pathology, then they said, well, it's really just, you know, the distress that you have, and that's what this thing was. This sexual orientation disturbance was all about, like, you're just stressed out because you're gay, and that causes you inner turmoil, okay? So this is where we live with gender diverse people. Your inner turmoil is the pathology. You are not the pathology, which is definitely an improvement. But a whole lot of gender diverse people would say, this is not great, okay? A lot of gender diverse people, in fact, would say, and a lot of professionals who work with gender diverse people would say that the dysphoria is actually because society is really awful to gender diverse people, okay? Also, in 2013, the United Nations issued a special report condemning non-consensual surgical interventions on intersex people. So that took until 2013. And I will tell you, these surgeries are absolutely still happening. Now, in 2020, remind you that was like 2 years ago, Lurie Children's Hospital in Chicago, major medical center, it's the very first hospital to stop medically unnecessary cosmetic surgeries on intersex infants and publicly apologize for the surgeries that they had performed. So shortly thereafter, Boston Children's joined this, a couple other centers, but most have not. And so we are still deciding how babies should be raised and surgically correcting them unnecessarily. Okay. Then in 2021, 21 states proposed legislation banning care for gender diverse youth, and that law actually passed in Arkansas. Okay. And then, not even happening yet, but next month, the DSM-5 TR will update language. And so what I've seen in terms of the drafts related to gender dysphoria is that it says experienced gender instead of desired gender as part of the diagnostic criteria, which is an improvement in language, but they haven't done away with it. So we're probably waiting until DSM-6 for something more definitive. But that's where we are. This has been a partial LGBTQ medical timeline. Questions about what we've done to people? Yeah. Yeah, so it's essentially making someone's clitoris appear more feminine, right? Or it's having a baby who had a very pronounced abnormality or surgical issue with the penis, a female, by making their genitals appear that way. It changes nothing about who the person is, but kind of making those assignments on babies. There's a million different ways that you can have genitals that are not consistent with the masculine or the feminine. And there are some sincere medical concerns, specifically around congenital adrenal hyperplasia, because those babies can have life-threatening salt wasting. And so you have to know what is a medical concern. Mind you, you don't need to do anything to their genitals to fix their salt wasting. It's just kind of a heads up, like you should check for salt wasting. But we so much want to normalize and fix and make things aesthetically the way that they are supposed to be. I'm doing a lot of air quotes, Zoom folks, that we force sex and we force gender on people. Does that make sense? Other questions? Yeah. Mm-hmm. Yeah. No, it's a really great question. These are complicated conversations, okay? And we're going to talk about one later. But what you got to realize is that there's a whole bunch of folks, generations of folks that have had this done to them, that as adults say that this was a horrible thing that happened to them, and that they wish more than anything their parents had not made that decision. And so parents have a right to hear those stories too, and not just us sitting there in our white coat saying, we can fix this, and you don't ever have to tell your kid, and it'll be fine. Because that is what we have said to families for 100 years. Okay? So it's not as simple as, we can fix it, we don't have to talk about it, we can put that in the corner and move on, right? These people have experienced shame and stigma their entire lives, and often we're not told about their own medical history. And that's the problem. Does that make sense? Anybody else? Okay. All right, so that was the world broadly. What about here at WVU? In 2018, I was part of this study, and we asked providers throughout the health system, this was residents and faculty, physicians, as well as some APPs, what they thought about caring for gender diverse people specifically. And so we used the language transgender people, and 40% of people said, you know what, we need more training on this. We were not trained enough. We want more. Okay, 23% acknowledged that there are significant barriers to care for this population. There are significant barriers to care for this population. I'm happy to give you 100 examples. So I was a little bit disappointed that more people didn't recognize that. 80% of people acknowledge that transgender patients have unique health risks and needs. Not bad, okay. This is the one that really got me. So 1 in 10 people endorsed questions indicating bias and active discrimination against transgender people. And so these questions were real bad. They were so bad that I didn't want to include them in the survey. And the pushback I got was, we have to see where the bottom is. And so these are questions like, trans people shouldn't be allowed to be around children. Okay, like really, really bad stuff. And 1 in 10 people said, yeah, they strongly agreed or agreed with that. So we had a lot of work to do. We still have a lot of work to do. But we've done some stuff. So this is Molly Fector-Leggett. They're an amazing advocate and champion. And they are the Special Programs Director for transgender health across the health system at WVU Medicine. And they have been absolutely essential in making sure that our non-discrimination policies included things like gender identity and gender expression, that we had training across the health system. So every member of the health system has had access for years now to training. There is online modules that you are happy to participate in if you would like. I'm happy to send them to you. we've done a lot of work here. There's still a lot of work to be done, but it has begun. Okay? And so for the last part here, I want to appraise opportunities for reducing health inequities for LGBTQ plus patients and colleagues through some cases, because my understanding is y'all like case-based learning, so we're going to do some of that. Okay, first case. You are a resident in a continuity clinic. It is Friday afternoon in your outpatient clinic because you're a resident, so of course you have Friday afternoon clinic because that's how life works. Okay? As a faculty member, I also have Friday afternoon clinic. It's super fun. It's a packed schedule, and your 4:30 p.m., which is your last patient spot of the day, they checked in. They're a new person. But then the visit was canceled. And so I won't lie to you. If a 4:30 patient on a Friday canceled for me, I'd be like, oh, I can like make dinner or something. I can see my family. Okay. Except this person probably needed care, right? And it's kind of strange that they checked in and then they disappeared. So what do? Do you go home and make the lavish dinner and do the thing? I would argue before you do that, which is important, you should take care of yourself and your family, right? Before you do that, maybe go and ask what happened at the front desk, right? So you do that. You go to the front desk, and you're like, what happened with the 4:30? And the front desk staffer says, oh, yeah. That patient checked in 15 minutes early like we recommend and was in the waiting room. She, I don't know, I'm new at this. I took the module, but I'm so confused, whatever. She asked to be called a different name than was in the chart, and so I told her to tell you that when she saw you. Then the nurse called the legal name, because, that's what's in the chart, and she got real upset, and she left. And then I had, this line of people to help, so I couldn't go after her, so I don't really know what's going on. Okay. So how could you help reduce health inequity in this case as the resident? I think it's pretty obvious what happened here, right? So a patient came in, was not treated respectfully, right? Did not have their name used, was what we call dead named in the waiting room, okay? And so, yeah, that's super rude. It's also kind of dangerous, right? And so that person's actual life might be threatened because you just outed them, okay? And certainly they're not going to see your office space as a welcoming environment for them. Why would they? And so in conjunction, you are not a welcoming environment for them, because why would you be? If your front desk staff doesn't treat people the way that they should be treated, and your nursing staff doesn't treat people the way they should be treated. That being said, the front desk staffer, they were trying really hard. And the nurse was trying really hard and had no idea. And so there's nobody who's the bad guy here. It's just that this is a system breakdown. And so when you're in these spaces, you got to recognize that this could happen, and there are 100 people that see your patient before you do. And every single one of them can make that patient feel unsafe. And so as the resident, you can't burn it down, right? And you shouldn't. But you can talk to people about what went wrong here and initiate quality improvement to make this not happen. You can also call this patient and apologize. Offer to talk to them over the phone. See if they have acute health needs that you can help with. Ensure them that you are happy to see them at a different time and space if they are interested, where this will not happen to them, and then make sure that it doesn't happen to them. Okay? These are things that you can do to reduce health inequity. People ask me, how can we actually make changes? This is how. Also, you can encourage the patient to go into their MyChart and fill out their affirmed name so that their name is, at least in quotes, the name that we should be using. Epic is complicated right now, so affirmed names are going to be in quotes and their legal name is going to be written next to it. But know that the quote name is the one you should go with. Okay? And hopefully eventually we'll be able to get Epic to just show the affirmed name. Epic is completely capable. It's the systems that we communicate with that aren't. It's a whole thing that I have meetings about all the time. Okay? Also, this is a SOGI form, a sexual orientation gender identity form, and it can do things like add somebody's pronouns, which is super helpful. Okay? So know that these things exist. These are tools to help you to affirm your patients. Case 2. Any questions about case 1? Okay. Case 2. You are an MS3 on a clerkship. You are in the elevator with your team. It's MS3 year. We're excited. It is July. Okay? We are past step 1. We are living our best lives. And your attending starts talking about this recent news story about this bathroom ban, and it's impacting trans people. And he says, I think I'm going to put on a dress so I can go peep at women in the bathroom. And then he and the fellow and the senior resident, they have a really good chuckle about this in the elevator. Okay? What do? So I'll tell you what I did. Nothing. I was scared to death. So this happened to me, July, my 3rd year. Okay? In this hospital. The person who did it does not work here anymore. But I didn't do anything. and I still regret it. I remember that moment. Okay? We have a responsibility to call out discrimination when we see it. It could be directed at our patients, at our coworkers, at ourselves, somebody else, but we have a responsibility. And I had a responsibility and I didn't do anything. So you have options for reporting witness discrimination. There is a mistreatment policy that I know you have to know about because it's one of those survey questions they make you take every year where you have to say, yes, I know there is a mistreatment policy. Here it is. You'll notice it includes gender. It does not include gender identity, and it does not include gender expression, things that I am seeking to remedy this week after I learned that it did not include those things. So stay tuned. It'll be there soon. Okay? Here are links to the HSC page and SOL that you can actually use to report. Another link is to that policy itself. You can also ask for a confidential consultation with the Dean of Student Services. You can submit anonymous reports in eValue. And if all else fails and you don't want to do any of those things, you can email Molly at transhealth@wvmedicine.org. This is a situation where we need more training. We need folks to understand that what was said in that elevator is not acceptable, okay? That this is not the environment that we have here at WV Medicine or the environment we strive for. And it's also not the environment we have at WVU. WVU does have discrimination policies relevant to gender identity and expression. And so as students of WVU, this is another discrimination policy that you can fall back on, okay? And so I want you to feel empowered to report things like this when they happen so that we can change the culture here, okay? I'm asking you to be better than I was. Case number 3, outpatient primary care clinics. So you are the attending physician. Congratulations, you got a promotion. It comes with a nice pay bump. Okay, so you are the attending physician. You're meeting a new patient. Your patient's John. He's 52. He has a history of hypertension. He's on hydrochlorothiazide. All right, and that's really all he's got going on. John's very nice. He shares that he's been married to his wife Jill for 23 years. They have a wonderful life. He has a boat. They have a great time. Okay, he denies any concern about sexual function. Not really interested in answering any of your questions that you have, like, do you have sex with men, women, or both? He's like, much with my wife. Okay. And you ask if he has any additional questions. We call this a doorknob question, right? You're leaving the room, and the patient's like, oh, by the way. Okay? John does one of these, and he's like, I'd like to get on that PrEP medication to prevent HIV. Okay? What do you do? Historically, you would now need to open a Pandora's box of, John, tell me about all of your sexual experiences and whether or not you're at risk for HIV/AIDS. Okay? Excitingly, you don't have to do that anymore because as of December 2021, according to this person, who is the CDC director of the Division of HIV and AIDS Prevention, if someone asks for PrEP, don't grill them. That's literally what he said. Okay? PrEP is part of good primary care. Listening to people and what they need, as opposed to assessing what you think they need, is a seismic shift in how PrEP should be offered. Here is a link to that statement in case you don't think that the guy said grilled, because he definitely did. Okay? So this is awesome. People who want PrEP can have PrEP. Okay? Insurance needs to get behind that, but people who want PrEP can have PrEP. PrEP, pre-exposure prophylaxis, prevents HIV. And right now, the versions we have are daily pills. There are 2 of them. They are outlined here. You'll see they're very similar in terms of what they contain. But soon, it was approved as of December 20th, 2021, though it is not yet available. We'll have cabotegravir, which is an injectable PrEP. So you get it every couple months, which is great, especially for my young patients who don't want to take a pill every day. But PrEP is primary care. And so if you're going to be working in primary care in any setting, you need to know that PrEP is a thing. Okay? You need to know about PrEP, know how you prescribe PrEP, know how you monitor PrEP. Good news is the monitoring has also become significantly less complicated. Okay? So PrEP is awesome. So also, just to kind of briefly review, I know Dr. Gannon spent a lot of time on this, but I want to talk about how we talk about sex. Okay? If you are embarrassed to talk about sex, you will never get the information from your patients that you need. Your patients will be embarrassed. Your patients will not share with you. You have to be good at this. Okay? We have taught you this. Do you have sex with men, women, or both? It's better than assuming people are all straight, right? It's better than that. But it's not great. It's not great for a couple of reasons. So the big one is, like, remember those non-binary people? Where do they fit in here? Okay? And if you're having sex with both, what kind of sex are you having? What orifices are you using? There's a lot that this leaves to be desired. Okay? So I would argue that you could get rid of this question entirely and instead say something like, are you sexually or romantically attracted to other people? Because we don't want to assume that everyone is. Remember, asexual people are the A. They get a whole letter. and they have a whole lot of experiences in their lives where it is assumed that they are having sex with people, that they are attracted to people. You can be attracted to people or not and still be having sex with people, right? So those are different questions. But I think giving space for our A's is important. And then, are you sexually active with partners currently? What body parts do you use for sex? I talked to teenagers about this, okay? I introduced teenagers to the concept of mucosal surfaces. I'm like, which mucosal surfaces are you using for sex? What do I need to swab to make sure that you're healthy, right? Here's some swabs. You want to swab yourself? This is what I do in clinic. Okay? Does your partner produce sperm or have a uterus? And so if your question is really like, well, I need to ask if they have sex with men, women, or both because I need to know they're going to get pregnant because I have to talk about birth control and I don't really know if I should. So someone saying they are, designated female, identify as female, so cisgender woman, comes into clinic and says, oh, I only have sex with females. Okay. Does that female have a penis? Do they make sperm? Right? And so that's the actual question you need to get to the bottom of. And so are you interested in testing for sexually transmitted infections? Are you interested in preventing HIV using a daily pill or injection every 2 months? These questions will actually get you someplace, much further than that one. So I encourage you to use what questions fit your flow. You will develop your own flow and cadence with patients. You want to ask questions that you feel comfortable asking because, again, your patients will know if you don't. But there's a lot of better ways to say these things than that. Next case. Any question about John and PrEP? Yeah. Yeah, and so it's possible that patients could react negatively to a whole host of things we say. And it's a really great question. So I always kind of cushion this conversation, like Dr. Gannon mentioned, with, I'm going to ask you some questions about sex, if that's okay. So you're asking permission. These are questions I ask of all my patients, and the more information you're willing to provide, the better advice I can give you. Right? So you cushion this in normalcy. This is something you do with literally everyone, and it's about their health. You're not going on a curiosity adventure. Right? And if they say, well, of course I'm straight. You don't need to ask me those kinds of questions. Say, I understand. I want to make sure I'm respectful of everyone. So I ask everyone these questions. Does that make sense? Yeah. Mm-hmm.
Where does that conversation go next?
Yeah.
Because obviously there's side effects of these medications. How do you weigh the risk benefits without discussing the risks that they're doing?
So what did you say before you started the patient on hydrochlorothiazide? This was a risk-benefit conversation, right? And so is this. Okay, I understand you want to be on PrEP. Let's talk about that. What do you already know about it? Let me tell you some more things about it. Are you aware that XYZ could happen? Are you aware that we need to do these monitoring labs? Is that okay? That's it. Just like literally everything else we do. In our minds, we make these things kind of big entities. In fact, everything we do is a risk-benefit conversation with patients. So it's just another one of those. Okay, now you're the night radiology resident. I really tried to mix it up, right? Tried to get like, maybe you're not into the whole patient talking thing. Maybe you want. Okay, so you're in the radiology suite. You are a radiology resident reviewing a pelvic ultrasound, transabdominal, overnight on a male patient with lower abdominal pain, pelvic pain. You review this image and you give measurements for the prostate. Now, to be fair, I did not have a really advanced ultrasound curriculum when I was a medical student. Oh, we're almost out of time? Okay, I'm going to wrap it up soon. Okay, but you did, and you continue to. So you might recognize that that's a uterus, okay, and not a prostate. The radiology resident at night at another hospital did not. So when I ordered that pelvic ultrasound, I failed to mention that the patient was assigned female and had had a legal name change and gender marker change several years prior. This is not the actual image, and the actual image the radiology resident saw probably had a much smaller uterus that may have resembled a prostate because that patient was on testosterone for several years and had subsequent uterine atrophy. Okay? But this is a problem, right? And it was complicated for me to then call my patient and explain, I have to have your image reread because there was an issue with the read that they measured a prostate that you do not have in your body. Okay? But it brings us back to the importance of that form in EPIC for an organ inventory. Okay? And so we can actually click in EPIC what organs people have in their bodies. That could have helped the radiologist. It also could have helped if I just said, patient is transgender, patient has a uterus. And so it's important that we communicate with our peers what we're actually looking for. I was worried about ovarian torsion. I did a terrible job explaining that. And instead I got a prostate measurement back. Okay? So this is a problem, and this is something that happens, I'm sure it's happened in our health system. It definitely happened in another health system that I was working in at the time. Okay, So real quick, intensive care unit, hemorrhagic stroke. Dan's 75. He comes in. You're doing your bedside assessment. Dan is in critical condition. That's why he's in your ICU. Nurse goes to place a Foley and realizes that Dan doesn't have a penis, but instead actually has marked clitoromegaly and otherwise female-appearing genitalia. What do? You take care of your acute patient. Dan had a hemorrhagic stroke. That is the most important thing. Okay, you get that Foley in. Then you go talk to Joan, Dan's wife. She's anxious, obviously. Dan just had a hemorrhagic stroke. But she's worried about that and wants an update. But she also shared that Dan is transgender and has never had bottom surgery because it wasn't important to him. And they have 2 adult children who know that Dan isn't their biologic father, but they don't know about him being trans. And so Joan asks that you ensure they don't find out. What do you do here? You protect Dan's privacy. Okay? This is going to involve you talking to the team, caring for him, limiting information to those who actually need to know to take good care of him. But real harm can come to those who are outed without their consent. And so you may be in a situation where you have the potential to out someone. Do everything you can to not let that happen. And our last case, you're the peds resident covering overnight. You get a call that this baby has ambiguous genitalia. Newborn had a non-invasive prenatal test. So the mom had this. This is cell-free DNA. Okay, these are $250, so you can get this. Order it yourself. Don't play with insurance. That's what I did. It was $250, paid cash. Somebody came to my apartment and drew my blood. It was great. I had all the information I wanted. I knew the risks and benefits of doing that. And a lot of people are doing that now, especially if you're 35 and up. You actually get it covered by insurance. And so chromosomes were XY. Parents are expecting a boy. Everything is blue, right? We have dinosaurs and fire trucks. And then this baby's born with a microphallus, biped scrotum, and testes are palpable bilaterally. How do you talk to these parents? So this is almost never a medical emergency. I did briefly mention before congenital adrenal hyperplasia. It actually, the salt wasting doesn't really start until day 5 of life, but you should begin the medical evaluation immediately if you have concern. The fact that this baby has testes that are palpable means this is not CAH, so you can take that one off the list. Okay? But you want to talk about all of these things. So psychosocial support is essential. Here's some key things you should say. Congratulations. Your baby is wonderful. Right? Your child's genital structures may have developed differently. That's usually due to differences in baby's hormones, not anything you did or didn't do, because parents are immediately worried that this is their fault. Okay. I recommend testing to explore more, understand more. This might involve blood tests, ultrasounds, an exam by a specialist. It might take a few days. Okay. How have you been talking about your baby? What name were you considering? This baby is a baby, it's someone's baby. Okay. Here's what you don't say. Your baby has a disorder of sexual development. That technically is the medical term. We're moving more towards variation or difference in sexual development, and I encourage you to use that language instead. We will be doing testing to figure out what is wrong with your baby. Don't say that either. Don't worry, this can be fixed with surgery. Actually, no. Most of the time this is a physiologic process. The case that I was describing is actually most consistent with partial androgen insensitivity syndrome, which is an interesting condition. You should look it up. But reassuring families can create some unrealistic expectations that are really hard to undo. Okay? And so this is something I was never taught that I encourage you to think about, because you will rotate through newborn nursery, and this is something that might come up. It comes up more often than you think. And so designation of your initial gender of rearing doesn't necessitate any particular surgical intervention or treatment, and that may or may not be the child's adult identity. Families need to balance a desire for the child's self-determination with the challenges of raising a child without a gender designation. That is particularly challenging. And so I'm happy to talk more about that in questions or in other spaces, but you have a lot of power to increase health equity. Here's one opportunity. Legislation that impacts gender diverse youth is very prevalent. And then later today, we're going to talk more about differences in gender affirming care, and there's actually an entire lecture series planned this week. Thank you so much. Questions? We got like 30 seconds. Okay. Please email me. I'd love to chat more. Thanks for your time.